The subcommittee will come to order. Before we begin, I'd like to ask unanimous consent for our friend and colleague and member of the full committee, Congresswoman Jackie Walorski, to sit on the dais and participate in today's hearing, and she will be joining us shortly. Without any objection, so ordered. Thank you all for joining us for today's subcommittee hearing, Evaluating VA Primary Care Delivery, Workload, and Cost. During today's hearing, we'll be discussing the findings and recommendations of a Government Accountability Office report regarding the primary care that is provided to veteran patients at Department of Veteran Affairs medical facilities across the country. I was glad to join many of my fellow committee members in requesting this report, which will be publicly released today, and I commend the GAO for their work. During their investigation, the GAO found that the Department lacked reliable data on how many patients VA primary care providers were seeing. The GAO also found that VA had failed to put appropriate oversight processes in place to verify whether the primary care data that the VA medical facilities were reporting was accurate, or to monitor the primary care that was being provided to veteran patients. For 6 of the 7 VA medical facilities that the GAO visited, panel size varied from a low of 1,000 patients per provider to a high of 1,338 patients per provider. The GAO found that the cost of the care in VA primary care clinics also varied widely. VA has been unable to respond to repeated requests for cost of care information by me and other members of this committee for more than a year now. But the GAO found that in fiscal year 2014, VA expenditures per primary care encountered ranged from a low of $150 to a high of $396 across the system, and expenditures per patient ranged from a low of $558 to a high of $1,544. Data inaccuracies, oversight, and management failures, and a lack of continuity or uniformity in care or costs across the country have sadly come to characterize the VA healthcare system over the last several years. Nonetheless, the GAO findings are alarming. For many veteran patients, an appointment with the primary care clinic is the first appointment they have at a VA medical facility. For them, primary care is the gateway to VA care. But without accurate data and effective oversight, the VA cannot guarantee that VA primary care providers are productively providing high-quality care, or that veteran patients are receiving timely access to care. And without minimizing variations in cost across the system, the VA cannot guarantee that primary care is being delivered efficiently from VA facility to VA facility. My suspicion, based on my 20 years of work as a contract physician at a rural VA medical center and 3 years as chairman of this subcommittee, is that primary care is not being provided efficiently or effectively at far too many VA medical facilities, and as a result, far too many of our veterans are falling through the cracks. Meanwhile, software that could have addressed some of VA's primary care data reliability issues was shelved over after the department had spent almost $9 million on it, supposedly because of a lack of the $1.5 million in funding that was required to implement it nationally. What's more, the department plans to take until September of 2016 to issue new primary care guidance, and until September of 2018 before findings and decisions regarding primary care encounter and expenditure data to strengthen primary care monitoring will be made. That's unacceptable, particularly considering that the GAO reported that some providers at facilities with high panel sizes have already expressed to VA medical center leadership that their ability to provide safe and effective patient care was being hindered by their workload. The VA must take action today to protect VA primary care patients and to help VA doctors and nurses provide higher quality care to our nation's veterans. I'll now yield to Mr. Takano, who is sitting in today for our ranking member, Ms. Brownlee, for any opening statement he may have.
Thank you, Mr. Chairman, for calling this hearing. Thank you. Today, the subcommittee is looking at the efficiency and effectiveness of the department's ability to deliver primary care to veterans enrolled in VA's primary care. Since 2010, VA has provided primary care services through a patient-centric medical home model of care called the Patient Aligned Care Teams, or PACs. The PACT teams are made up of physicians, nurse practitioners, physician assistants, as well as support staff. This model is designed to improve access, continuity, and care coordination, among other things. Many veterans seeking medical health services have benefited from this model because they have not been subjected to the stigma attached to visiting a mental health clinic. While we have worked hard to destigmatize mental health, I understand this is still a challenge for many veterans. In its written testimony, VA reminds us that it is difficult to compare VA's enrollee population to that of the private sector. VA patients are older and sicker than their counterparts, and overall, 20% have documented mental health diagnoses. In order to get the right care to the right veteran, the VA needs to know how many veterans are being treated at each facility. The report the GAO released today found that VA data on primary care panel sizes are unreliable and that proper oversight mechanisms are not in place. Due to the absence of reliable panel size data and oversight processes, GAO concluded that this could significantly inhibit VA's ability to ensure that facilities are providing veterans with timely, quality care that is delivered efficiently. GAO also found that VA was in violation of federal internal control standards. As you know, Mr. Chairman, VA's primary mission is to provide high-quality, safe health care to veterans. A top priority for this subcommittee is to ensure that VA has the tools and resources it needs to enable that to happen. I thank the witnesses for their testimony today, and I look forward to hearing from our panel. Thank you, Mr. Chairman. I yield back the balance of my time.
Thank you. Joining us on our first and only panel this morning is Randy Williamson, Director of Healthcare for the Government Accountability Office. We are also joined by Dr. Thomas Lynch, the VA Assistant Deputy Undersecretary for Health, Clinical Operations. And Dr. Lynch is accompanied by Dr. Richard Stark, the VA Director of Primary Care Operations, and Dr. Gordon Schectman, the VA Chief Consultant for Primary Care Services. Thank you all for being here this morning. Mr. Williamson, we'll begin with you. Please proceed with your testimony.
Thank you, Mr. Chairman and Mr. Takano and members of the subcommittee. I am pleased to be here today to discuss GAO's report released today on VA's processes for determining and overseeing workload capacity at its primary care teams at its medical centers. Primary care services are often the entry point to the VA healthcare system for veterans, and these services are delivered by primary care teams consisting of physicians, nurses, and support staff. Determining how many patients to which each primary care team can reasonably deliver care, referred to as the panel size, is critical to ensure that our nation's veterans receive timely, quality care and is delivered in an efficient manner. For example, if panel sizes are too high for primary care teams at a particular facility, this may lead to veterans experiencing delays in receiving care, whereas low panel sizes may be associated with inefficiency and wasted resources. To better ensure that VAMCs have reasonable primary care panel sizes, VAMCs are required to record and report panel size data, including the number of primary care providers, support staff, and available exam rooms. VA Central Office inputs these data into a model it developed, determines the appropriate primary care panel sizes for each VAMC, and provides this data to VAMCs. However, VAMCs can deviate from these model panel sizes as they see fit. We attempted to compare VA's model panel sizes with actual panel sizes for all of its VAMCs, but we found that system-wide, some data that VAMCs record and report to Central Office were inaccurate and unreliable. For example, panel size data included patients who had died or who had not been seen in the last 2 years. Also, there were missing data, and the number of reported exam rooms were sometimes erroneous. Absent accurately reported data, VA's central office has no good way of determining whether primary care panel sizes are too high or too low. We conducted detailed reviews at 7 VAMCs, and after correcting reported inaccuracies at 6 of them, we found that actual panel sizes ranged from 23% below to 11% above the model panel sizes that central office determined to be appropriate at these locations. Panel sizes for these VAMCs range from 1,000 patients per full-time provider to 1,338. VAMC officials attributed the differences to varying degrees of patient demand, staffing shortages, and/or exam room shortages. Some VAMCs decided to establish lower panel sizes to prevent provider burnout and attrition. Other VAMCs with higher panel sizes were experiencing staff shortages due to recruiting and retention difficulties associated with rural locations or the inability to compete with higher pay offered by the private sector. Also, some VAMCs were not affiliated with a university medical school that could have provided a supplementary pool of physicians. We also found that costs for primary care visits, which can be an important measure of how efficiently primary care is being delivered, varied widely at VAMCs. The cost per primary care visit varied from $158 to $330 at the 7 sites that we visited. We also found that oversight to better ensure accuracy of data VAs submit is basically lacking. Moreover, even if accurate primary care panel size data existed, neither VA central office nor many VISNs performed systematic oversight to identify large gaps between the model panel sizes and the actual panel sizes at its facilities. Also, cost per visit data is not even considered to be relevant as a measure of how well VAMCs are managing the delivery of primary care services. Absent meaningful oversight to correct potential imbalances in primary care panel sizes, some VAMCs may be putting veterans at risk by not providing timely quality care. For example, one VAMC we've reviewed with the highest panel size, 1,338, had a vacancy rate among its primary care providers of 40%. Some primary care providers at that facility expressed concern to VAMC leadership that the high panel sizes were impeding their ability to provide safe and effective primary care services. This situation is all too reminiscent of veterans' access issues that have arisen at other VAMCs in the recent past. The problems with poor data and insufficient oversight that we noted in the report are precisely why GAO added VHA to our high risk earlier this year. To correct the issues we noted in this study, we made several recommendations to improve data accuracy and establish a more robust oversight process. While VA concurred with our recommendations, we are concerned that VA may not be moving fast enough to make needed improvements. Without major improvements, VA is likely missing opportunities to identify VAMCs that warrant further examination and to strengthen the efficiency and effectiveness of primary care. This concludes my opening remarks.
Thank you, Mr. Williamson. I appreciate it. Dr. Lynch, please go ahead.
To discuss the delivery of primary care services to veteran patients by the Department of Veterans Affairs. I'm accompanied today by Dr. Richard Stark to my left and Dr. Gordon Schectman to my far left. Mr. Chairman, VHA has over 5.3 million veterans enrolled in primary care. We have almost 1,000 sites of care, and over half of the patients receive care in community-based outpatient clinics near their homes. In many rural areas, we provide care via telemedicine or in mobile medical units. In recent years, we have implemented extended hours, and all patients have access to after-hours medical advice call centers. The majority of our patient population has multiple chronic diseases. VA patients are generally older, more complex, less healthy, and less socioeconomically well off than those in the private sector. Veterans have a higher prevalence of common chronic health conditions such as diabetes, hypertension, and heart disease. Overall, 20% of veterans have documented mental health diagnoses, and most of our primary care sites have integrated mental health capabilities so that patients do not have to travel for routine mental health care. In addition, our primary care teams have training and experience identifying and managing combat-related sequelae such as TBI or PTSD. Beginning in 2010, as Congressman Takano mentioned, VA began providing primary care through the patient-centered medical home model of care. VA refers to these as patient-aligned care teams, or PACs, and they involve a team-based approach to health care. Through the PAC, patient care is not only provided in person in our clinics, but also through virtual modalities such as by telephone, email, or by telemedicine. This team-based model is also being used to explore new venues of providing primary care, including the provision of care in the home through video technology and the use of scribes in the clinic setting to enhance provider productivity and patient satisfaction. The more than 8,000 PACs are made up of a variety of clinical and clerical staff, including physicians, nurses, and clinical assistants. It has been demonstrated that patients who have been placed in well-implemented PACs have lower hospital readmission rates, improved levels of patient satisfaction, and higher results on measures of quality of care. Overall, VHA exceeds the private sector in outpatient measures of quality such as preventive care and the management of diabetes and cardiovascular disease. While facilities must have the flexibility to adjust panel size based on local resources and patient complexity, central oversight is also important, and reliable panel sizes are essential to assure continuity and coordination of care. VA is appreciative of GAO's findings in this regard and agrees that greater oversight and responsibility for the accuracy of data are needed. Through the changes recommended, our processes to identify and manage instances of significant variation will be strengthened. Primary care leadership in VA has also recognized the issues of our aging data systems and has been contributing, and that this has been a contributing factor with regards to inaccurate documentation and the monitoring of panel size. In response to this issue, a redesign and re-engineering of the software that tracks and helps manage patients, the primary care management module, has been underway and will begin full deployment this year. The upgraded database will enable both greater control over the accuracy and reliability of panel data and more granular and precise data about staffing and space. The report by the GAO also found that primary care cost data reported by VHA facilities were reliable but subject to variability. And we concur with the GAO's assessment that VA is missing an opportunity to potentially improve the efficiency of primary care service delivery through heightened oversight of encounter use and costs. When considering cost, it is important, however, to note that the comprehensive integrated services offered by PACT are generally not present in the private sector. PACs offer integrated mental health care, social services, coordination with non-VA care, as well as prevention and wellness support. However, many of these services are housed in medical centers which are often aging and not properly configured for efficient outpatient care. This makes cost comparisons with non-VA care models difficult to accomplish. Mr. Chairman, VA continues to be a veteran-centric organization and to deliver patient-centered world-class health care. This concludes my testimony, and we look forward to further discussing VA primary care with the members of the committee.
Thank you, Dr. Lynch. I'll yield myself 5 minutes for questioning. Actual panel sizes for 6 of the 7 selected facilities where we were able to use updated data provided by each facility and corrected for inaccuracies. So the data that the VA gave you initially, that was not adequate for you to do any analysis at all. Is that right?
Correct. We got data from VA and we looked at it and did some further investigation, and we saw a number of outliers that just didn't look right. And as we explored those at the sites that we reviewed in detail, we found out indeed they weren't. One of the biggest issues was there were a number of people that were in the panel sizes that were either had died or had not been seen in VA for the last 2 years.
So this data that the VA gave to you, Dr. Lynch, that's the same data you use to analyze what's going on there?
I think, Mr. Chairman, VA has made some significant changes since this report was put together, and we'd be happy to discuss those further with you.
Well, it's just of concern to me, while I'd like to know what those are, but it's of concern to me that, Mr. Williamson says that the data you're collecting isn't useful without going over it a second time and fixing it up so that it made some use. So that of, great concern to me. And, one of the things I've been trying to do in this committee is to try to get the VA to collect more data. The panel size, to me, I don't know that that's the biggest issue, other than the fact that it's a guide to how many providers you need. But certainly I think that there should be some discretion at the local level to decide what the panel size should be so that you prevent this burnout issue, and that 1,200 may not be the right number. It might be different in different areas, so I can understand that. What I'm concerned about, though, is a little bit about the cost per visit. That to me seems to be an more important part of it, because it's difficult for me to figure out, and I don't pretend that there should be the same cost per visit as it is in the private sector for many of the reasons that both of you discussed. But does the cost of the visit, does that include the facilities charges too? I mean, like the rent of the place that you're at, or the cost of the building and the utilities, is that all a factor in there?
It includes everything, including depreciation and so on. I'd also like, Mr. Chairman, to go back to something Mr. Lynch said. The data that we have in the report is still flawed. I mean, the data that VA has in the system, and probably the figures that they gave you, is based on flawed data. The improvements that they have planned on, the new PCMM software, will correct a lot of it, but that hasn't been implemented yet, and I take issue with the fact that data is accurate.
Well, right. I mean, that's the whole basis of this hearing, is the fact that they may be making plans on data that has no validity, and then to make a plan. Then when the change in the plan doesn't work, then there's a surprise, and it's a problem. But I'm just concerned about the variability in the cost, and
Yes.
As I understand it, the variability took into account already the variability based on location.
All right.
And I don't understand why there's such a huge difference in the
Well,
cost.
some of the reasons we were given when we were at we did detail work at the 7 facilities. For example, some facilities use telehealth and telephone calls extensively, while others don't, and that is one reason why a facility may show lower costs. Is
Does the data include like the severity of the visit, or the severity of illness of the patient, and the degree of complexity of the visit? That's not included in this?
No, it's just basically the cost, all the costs associated with that particular encounter and the encounter itself.
So, Dr. Lynch, does the VA collect any of that data? I mean, like, Medicare, when you do a patient visit, you have to check the complexity of the visit. Does that happen in the VA?
Yes, sir, it does.
So, where is that data? I haven't.
So I
seen
guess I
anything
would
like.
ask Mr. Williamson whether their data was raw data, or whether they adjusted for differences between facilities in terms of the age of the facility or the complexity of the patient.
We adjusted for labor costs, because labor costs are a big factor, say for Los Angeles versus St. Cloud, very big difference. So we adjusted for labor costs and then used VA data for that.
But for age of the facility or complexity of the patient population, there probably needs to be some adjustments as well.
That's right. That's the reason that you want to, if you see big variation, that could very well be a reason for it, and that's why oversight would help you identify that, as opposed to inefficiencies that may be happening. Yes, there are a number of reasons why those costs could vary.
Do you have the data on the complexity of the patient visits, Dr. Lynch?
We do, sir.
It would be helpful, I think, for the subcommittee to see, like what is the average intensity level of the visit? You know what I mean? Because I don't remember exactly the numbers. Maybe Dr. Abraham remembers. He's closer to private practice than I was. There's because like a level 1, 2, 3, 4, 5 outpatient visit, and I can understand having complex patients that have a higher complexity, would cost more. But I think we need to have that information on a regular basis to sort of monitor and supervise how the VA is taking care of patients. Is there a way of doing that on a regular basis, Dr. Lynch?
I would hope we can find a way. Speaking as a clinician, I don't disagree with you. I think the more data we have to identify how best to treat patients, the better off we're going to be. So I'm not arguing with anything you're saying. I think with respect to the GAO report, we are aware of a number of the deficiencies. The PCMM model, which either Dr. Stark or Dr. Schectman can speak further about, will help us basically look at panels and make sure they are properly impaneled. It will help us work through and eliminate those patients who may have died or may not have used VA care. These are all important things. We need to know that, and you probably need to know it as a committee.
I'm sorry, I realize I'm over time. I'll yield now to Mr. Takano.
Thank you, Mr. Chairman. Mr. Williamson, did I hear you correctly? The chairman asked a question that I am interested in about the underutilized space and how that factors into your conclusions. Did that factor into the cost of care?
No, it didn't. But, as you know, many VA facilities are old and were built when we had more of an inpatient model, and the issue of shortage of exam rooms came up quite a bit. But if you're looking at cost per encounter, it's going to be hard to factor in exam rooms and whatever unless you do a specific analysis of that facility. And we looked at that as and that was cited as a reason for a higher cost, but it's hard. We just used the data that VA gave us on that.
So you didn't factor in the
no.
So the cost differentials wouldn't reflect.
No, we did labor costs.
Okay. Dr. Lynch, the report references a pilot project regarding primary care management module at the Primary Care Operations Office at selected facilities in 2014. It was mentioned in the chairman's opening statement. It was planned to be implemented agency-wide after resolving certain software interoperability issues. Why is the implementation on hold, and when will it be implemented system-wide?
So I'm going to pass this off to Dr. Stark, but I want to make the point it is no longer on hold. Dr. Stark,
it's being implemented now?
it is in the process of being implemented.
Okay, Dr. Stark?
Yeah, the PCMM web, which is what we call the new software that we've developed, was deployed at 4 pilot sites a little over a year ago. As a result of that deployment, some problems with interoperability were identified, and further work needed to be done. It was determined that extra work would result in additional funds being needed to complete the contract.
It was $1.5 million?
That's the $1.5 million.
Were you able to find that, or
yes.
you were able to implement
yes, the Office of Information Technology had to pull money from a number of other projects and identified some excess funding, and they were able to locate that funding, and we're back on track, and really that resulted in a delay of only 2 or 3 weeks in the deployment schedule.
Okay, so we're moving ahead with an improved data collection. This concern over data that's not adequate for the GAO, the VA is moving ahead with trying to resolve that.
Yeah, this software has been a long time coming, and one of the reasons for developing it was to correct some of the issues that we had with inaccurate data and replacing the old software that had really been in place for 15 or 20 years and had been patched in all kinds of ways over the course.
Well, this is news I wasn't expecting to hear. I'm glad to hear that VA is moving forward with improved data collection so that we can get a better handle on per patient costs. You know, the GAO has also found that the VA was in violation of federal internal control standards. Dr. Lynch, what are you doing to ensure compliance going forward with those standards?
The VA is taking this very seriously. Dr. Carolyn Clancy, who is the interim undersecretary for over a year, has taken that on as one of her tasks to begin addressing the concerns the GAO has that have placed us on the high-risk list. And that includes looking at policies and implementation of our policies and assuring that we have proper data resources.
Dr. Lynch, I'm very concerned about something that's been said in previous testimony in different hearings. I understand from testimony by a man named Mr. Grior, or it could have been Ms. Grior, I don't remember who, the gender, but 43. It said this person testified that 43% of network directors had acting director status. 16% of VHA medical centers lack a permanent director. More than 2/3 of network directors, nurse executives, and chiefs of staffs are eligible for retirement, as are 2/3 of those existing staffers, as are 47% of medical center directors. As you try to address a topic like this of being in compliance, which to me is a managerial challenge, I know very well what happened when I was on the board of a community college. We had an acting chancellor, and how that acting chancellor was limited in their ability to actually move the institution forward. If we had acting presidents of campuses, but having acting directors, almost half, I have to imagine this has an impact on your ability to make sure that we are in compliance with a standard like this.
It does, and VA is moving to fill those positions as rapidly as we can, and we appreciate the help that Congress and the committees have given us in creating the leeway to do that. But you're absolutely correct. We need to fill those positions. We need to get permanent managers in position and help us move the system forward. No argument.
I know you have a challenge because I understand that frequently administrators are compensated at 70% below the private sector for comparable positions, but I also understand there's been a real challenge within the VA in terms of personnel and your personnel office and in a number of different respects. But I would say this is a very critical thing with so many acting administrators.
Two things, I think. Number one, there is a bill that is currently under consideration which would allow us to use the hybrid Title 38 designation for medical center directors, non-physician medical center directors, which will help us increase salaries, make positions more desirable. I think we already have one of the most desirable missions of any healthcare system in the country, which is treating veterans. And I think we've been working with HR to try to develop a more efficient process to hire people. We recognize those as challenges, and we've been trying to work on those, sir.
I thank you, Mr. Chairman. Indulge me, and I thank you for your testimony.
I hesitate to say anything because I ran over too. Dr. Rowe?
Thank you, Mr. Chairman, and thank you all for being here today. And the whole point of this hearing is how to more efficiently provide care for veterans. It's primary care, which is the entry level for most folks. And the entire country now, medical profession, is undergoing a transformation. Many of us on this panel this morning who are physicians started our morning out with the American Group Medical Association, representing 175,000 private practice doctors around the country. And they're figuring out with ACOs and the new payment models, which is pay for performance and outcomes, how to negotiate this and how to become more efficient. And I think the VA may still be stuck in the older model and really needs to look at what's going on out in the private sector. I want to look at, Dr. Lynch, you said a couple of things about the VA panel, the VA panels are older and sicker and so forth. I just looked up at the NIH website while you were saying this, and 18.5% of the population in general, 18 and over, have a mental illness. Doesn't mean they're in treatment, but they have mental illness. So the incidence is the same as the VA. And if you look at the incidence of a soldier recruited today versus the population in general, they're the same. So I don't know that, and I know Mr. Williamson, we've had an opportunity to talk, and I think that you, in your testimony, you stated that the demographics of the VA patients, are, at least Dr. Lynch did, VA's written testimony, are consistently different from a majority of the private primary care practices. Is that data accurate? Because I don't believe that it is. I think taking care of veterans is like taking care of any other patient.
Well, as far as setting the panel size at 1,200, which is kind of the rule of thumb for VA, VA did an extensive literature search, so they tell us, and that because of the acuity in older patients and the acuity levels, they set those lower than the private sector. And I'm not here to tell you that's right or wrong, but that's the reason and the rationale they give.
And a typical panel, and I will just tell you, having practiced medicine for 31 years, many doctors undercode in the private sector. And I will, as we go around, you'll find out that we undercode what's actually done. So that our data may not be accurate either. You think, well, I don't want Medicare to come in and look at all this. So, I mean, I know that I probably undercoded the severity of the illness of the patients I was taking care of. I heard Dr. Lynch, and I want to expand on this a little bit because I believe you all are on to something. By helping make these panel sizes, look, the panel size we know with the VA is about half the size that it is in private practice, approximately. And I think you can increase the efficiency and the satisfaction of practice by having someone do two things. One is provide an adequate space for the doctors to work, and then an adequate support staff. And the adequate support staff meaning let the doctor be the doctor. And the scribe you're talking about, I think every office visit I make practically now is that there will be someone there to enter the data into the computer. It's an added cost for a practice, but I also think it adds tremendous efficiencies. How many places, how many scribes are you actually, because the medical center where I am in Johnson City, Tennessee, I don't think there are any.
I'm going to ask Dr. Schectman to address that question.
Yeah, so the concept of using scribes to enhance efficiency, productivity is a very attractive one. We have explored what's happening in the private sector in order to understand better, and we've really networked with advocates of this. There are scribes here and there in the VA, but what we have done is established a formal pilot in order to.
There is not a formal pilot. I think the secretary said there was the other.
No, there is. I'm saying we have a pilot ongoing now to evaluate scribes.
Where and how many?
There are currently 3 sites and only about 4 or 5 providers.
How many? 4 or 5?
Right. So it's a limited.
Oh, it's nothing.
It's limited.
That would be pretty limited. When
But we are planning on expanding it. We have sites who are interested in participating, and we are planning to add them, and also including a comparison with voice technology, so that we can really see whether or not.
Again, the motivation, I think, is different. Just to give you an example, all of us up here are private practitioners, and if I'm going to see 25, 30 people a day, and I've got an electronic health record that takes me 2 minutes or 3 minutes longer to do that than it does, I've added an hour and a half for the last patient's an hour and a half late. The VA doesn't, I don't know how many they saw, but I did just some quick calculations. If you have a panel of 1,000 and you see 10 people a day, which is not really hitting it too hard, that's 2,000 visits a year based on 10 months. And that's 2 visits per person per year, which, as Mr. Williamson said, some people are, and I admit it is hard. So, I mean, patients of mine died too, and I didn't know it till they didn't come in a year or two. I saw the obituary in the paper. I get that's hard to figure out. But you will, after a year or two, figure out when they haven't been in. You make a phone call and find out. That's what we did. You haven't been in for your appointment.
We agree with the need to explore this further.
Okay, thank you. I'll yield back, Mr. Chairman.
Ms. Custer?
Thank you, Mr. Chairman, and thank you to our panel for being with us. One of the questions that I wanted to explore hasn't been discussed yet, and if it's not in the realm of this conversation, I'm happy to move on. But I know we've heard on this panel before about the difficulties with scheduling, and it occurs to me that that's one of the primary obstacles to running an efficient panel, is knowing that when a physician comes in the morning, they're going to be seeing people throughout the day, and they're not going to be waiting for appointments that were canceled. It seems to me a couple of years ago, I spoke with a vendor who had a very efficient system. They just scheduled the most likely to show up in the morning, the less likely to show up in the middle of the day, and the least likely to show up at the end of the day, when they can double or triple book and make for a much more efficient day. And I just had a question: is that taken into consideration, or is it something that is being considered going forward so that the physicians that we do have can work in an efficient way?
So that specific model, no, but I will let you know that VA has awarded the contract for our new medical scheduling appointment program. It will be pilot tested in Boise, Idaho, to assure that it delivers what we expected it to deliver. We are also in the process of implementing some scheduling enhancements, which will be rolled out over the next 6 months to help our schedulers work more efficiently and provide better scheduling opportunities. VA has also looked at the no-show rate, the missed opportunity rate. We have several initiatives in place. We do have a program and an algorithm that allows us to identify those patients that are most likely not to show up for an appointment. Right now, the strategy we're using is to try to contact those patients and confirm their appointment, but certainly it would be worth looking at different scheduling alternatives to see if that would be a useful technique as well.
And absolutely contacting the patients. I remember I was shocked to hear that that hadn't been going on. So I think all of us in the civilian world rely on that reminder, even if it's an automated call. My other question has to do with the associate providers and the use of associate providers, PAs, medical assistants, nurses, and the like. Did you look into that in terms of efficiency, or were you solely focused on the physician panels?
I'm going to let Dr. Stark take a shot at that.
Yeah, currently about 30% of our primary care providers are non-physicians. So they're nurse practitioners, which I think is about 24%, and physician assistants are about 6%. So we make extensive use of those other healthcare professions in primary care, and they've been very helpful to us in helping us meet the demand.
And are they folded into your data? Is a typical panel for a nurse practitioner also 1,200 patients?
No, actually the panel size for a nurse practitioner or a physician assistant is generally set at about 75% of a physician panel. But nevertheless, that data is part of the panel capacity information that we use, so we take that into account.
And then the last question I have has to do, again, efficiency, speaking on behalf of the VISN, the hospital in White River Junction, Vermont. I'm in New Hampshire, but most of my veteran constituents in the northern part of the state go to the Vermont facility. They are having wonderful success with telemedicine. I was surprised to learn actually in mental health, very, very effective. Vets are very comfortable once they get settled into the chair and have the eye contact. Did you take that into account, and is that a direction that other VISNs could follow for greater efficiency, greater effectiveness, and keeping costs down?
Absolutely. We have used telemedicine in a number of our sites, particularly in rural areas where it's difficult to recruit providers. Telemedicine can really serve a lot of the needs of veterans without requiring that face-to-face visit. In some places, they've even set up sort of telemedicine hubs where they find it easier to hire staff in a particular location those providers see a panel of patients at a distant location on a regular basis. So it's an effective tool, absolutely.
My time is up, but I would also note that they're having great success with PT, physical therapy, in a distant location, which I was impressed by. People could just stay at home. So thank you very much. Thank you, Mr. Chair.
Dr. Abraham, you're recognized.
Thank you, Mr. Chairman. Thanks to the panel for being here. And I think we've got 3 primary care docs here and then a health director here. So this is a good captive audience. And I'm going to hit this from the private sector like Dr. Rowe did. Mr. Williamson, you said that these hospitals that were built back in the 60s and 70s were more built for our inpatient population, and we get that. But when we're having veterans wait too long to get an appointment, when they get there too long to see the doc or the NP or the PA, you know, I ran a multi-physician practice, and I really didn't care what the docs or the NPs really cared about it. I cared about the patient. And how hard would it be to open up, let's say, an inpatient room, make that an exam room? You've got a bed, you've got a couch. All you need is a stool for the doctor to roll around in. I carry the otoscope in my right pocket, my stethoscope in my left, and we're there. That's such a simple thing to utilize a facility that you already have in place and that you already are paying the electricity on anyway. So again, just, you know, common sense. The 3 docs can tell you we could convert that hospital room into an exam room in 15 minutes or less and be ready to go to work. And, you know, whether the NPs or the docs had to climb the stairs to get there, that's not really, I really don't care as long as the patient can get there and see somebody. Going back to Dr. Rowe's comment about the scribes and the undercoding, and he's exactly right, because we get so wrapped up in not knowing how to use the software, it takes us forever to code a visit. A scribe is an expert. They have been trained in that. And what I can tell you, we got scribes in my practice. Once we started using them, we never overcoded, but we coded appropriately. Revenues went up. We saw more patients because the scribe knew what they were doing better with the software than we did. So, Dr. Schectman, back to your comment, I would advocate, and I can show you hard data across the nation where scribes have enhanced profitability in the VA system or in any system, any private business. But more importantly, you get to see more patients, and you get to see more patients in a very effective manner. You get to be the doc, as Dr. Rose said. We're not typists, and we're not certainly scribes. And going back to data collection, we've got ICD-10 out right now. And if you guys have looked at it, which I know you have, ICD-10 has software where you can collect this data on patients seen, what their diagnosis is, what their treatment outcome is. So my point is this. I understand that, you know, you guys are a government bureaucracy and you have to move a little slower because you're dealing with taxpayer monies, and we get that. But, you know, I want to say that from the business model point, this is not nuclear physics or rocket scientists. This is pretty simple stuff. And when we as private doctors have to actually make a payroll, and we're responsible for families making a living and taking a paycheck home to their children, we know how to do business. And the VA could do this. It's not that hard. So again, just more of a statement than a question. And again, I think, Dr. Lynch, you said something about voice recognition software. We're trying to get it with the VA. Well, you know, we've got that. Dragon Speak or any of the Dragon models, they've been working for 15 years, and they're wonderful. So, you know, in private industry, all these things are available, and they're available now. And I think we need to think about incorporating them in the VA system. Thank you, Mr. Chairman.
Thank you. Dr. Ruiz?
Thank you, Mr. Chairman and Acting Ranking Member for holding this. I'm not a primary care doc. I'm an emergency medicine physician, and we were born because the system was broken and there was a high demand and people could not see their doctors, or there was an emergency that needed immediate care. And from there, we developed efficiencies within the emergency department to take care of the patients. When there's not a bed, we use a gurney in the hallway. We double up. We do whatever it takes to take care of the patients. And I think that has always been my point, and I want to stress with the VA healthcare system, is that we need to move from a institution-centric system to a veteran-centric, treat the veteran first mentality, and try to have all the flexibilities that we can to make it work. And in saying that, I've done a lot of work with physician shortages in rural areas in my district and others, and I've done research on this matter. And when you approach a physician or a panel size difference for the healthcare provider, there's oftentimes a mentality where we need to look at this in the perspective of the physician. In other words, match the patients. In other words, call the patients the burden for the physicians to create wellness in the physician's life so that they can have a better experience, right? Or you can look at this as in a patient perspective and say we need to make sure that we have the adequate amount of physicians in the pipelines and train the physicians and the staff and to meet the patient demand. So there's a difference in the perspective in that, and I know that you all understand that. I just want to make sure that that's the central point, is that we are looking at this in the perspective of the patients, and in the short term, utilize whatever means necessary to get them the care, either in the VA facility or outside of the VA facility, but give the care the veterans need. Otherwise, they will end up in the emergency departments because they can't see their doctors, or because their diabetes got to an extreme point, or their mental health has deteriorated and is to a point where they need to be institutionalized. And one of the things that our country has defined as an adequate ratio in the community is 1 physician per 2,000 patients or people. To be considered medically underserved, it's 1 to 3,500. So my question to you is, where do you get the panel size of 1 to 1,200? And second is, have you looked at counting simply the full-time equivalent physician for a VISN per population, veteran population size of a VISN, and just utilize the 1 to 2,000 ratio to determine if you have enough physicians within that VA system?
Dr. Schectman, do you want to?
I appreciate those comments. Regarding panel size, there is controversy in terms of what's the right panel size. I agree with you. A lot of the literature does suggest, for example, that panel size should be 2,000 or greater. There have been pushback in the literature, actually, that this is too much, that in fact this would require, in order to provide comprehensive care the way patient-centered medical homes do, this would require providers working 20 hours a day, really, in order to get all the preventive care done, as well as the acute care, as well as the chronic care done. So the pushback has been to lower it, and this article that I'm thinking about really recommended lowering it to 1,700 or 1,800 for the private sector, but noted that in the VA, due to the complexity of patients and other issues regarding the way teams are configured and the way care is delivered, that a panel size of 1,200 or 1,300 is very, very appropriate. In fact, the independent assessment reviewed this very, very carefully and devoted pages to describing this issue about what's the right panel size. And actually from the AAFP took a formula, which the AAFP is advocating, and applied that to the VA and came up with a panel size recommendation very, very similar to our modeled panel capacity. So I don't know, considering all of the issues involved in terms of panel size, I don't know if we're too far off the mark. I think it's very hard to compare us to the private sector without really a lot of due consideration.
Well, there's different comparisons you can make with different institutions that provide similar care and departments that provide similar care for similar type patients as the VA. I think the overall point here is, what are you going to do with the data? And second of all, don't wait for the data to act. Don't wait for the data to get more physicians, more ancillary staff. I mean, it's the common sense. It's the patients that are waiting in the lobby. It's the patients that haven't been seen. It's the patients that are waiting that need the care. So don't wait for the data. It's good to have the data so you can make better decisions, but don't wait for the data. And the end goal is to add more support for the patients, not to have a comfortable patient load to make the physician's life better.
We agree with you 100%.
Thank you.
Thank you, Dr. Ruiz. I just want to make a brief comment, and that is, everyone's saying that the VA patients are sicker, but you haven't really shown us any data to actually prove that. I mean, I understand that, having worked in the VA, but you haven't shown me a list of, the complications that people have. There's nothing like that. So
I would refer you to Assessment A of the independent assessment, which does address the issue of VA demographics and does come to the conclusion that VA patients have a higher comorbidity than those in the private sector.
That's the data I like to see.
Thank you, Mr. Chairman. Thank you all for being here today. I appreciate it. One of the things I'm trying to get a grasp on is we talk about this ratio of doctor to patients in primary care. It can vary from practitioner to practitioner, and is there a local flexibility to that? And also, locally, being able to try to figure out why within the same facility one is able to see more than the other and do it effectively. For example, in our practice, we had 26 doctors. If one's seeing 50 patients in a day and another one's seeing 25, there may be a reason for it. It may be as simple as you need another medical assistant, which more than pays for itself, right? So I'm just curious if there's that flexibility on a local level to adjust in a couple of ways, either give a practitioner more patients if they're able, or adjust how they're operating to bring that level up.
Dr. Stark?
Yeah, there's definitely flexibility at the local level. That's one of the things that's very important to us, which is why our modeled panel sizes are basically recommendations and kind of a starting point. And then we allow the local facility to adjust the panel sizes to the characteristics of the practice, the characteristics of the providers, the resources they have available, so that they can tailor their resources to what they have to make sure that their veterans get the best of care.
And are the supervisors or administrators of these facilities keenly aware of this and working towards that, or does it take the practitioner to bring attention to it?
Well, in most cases, the primary care leadership is very attuned to this and adjusts those panels on a regular basis. And we provide them guidance on how to do that as well.
And there are some models that may be similar to the VA setting. I mean, I understand the difference between your typical private practice, fee-for-service, et cetera. But as far as the proper patient load, it seems to me, I know in DOD, still serving in the reserve, there's this move, especially in the Army, that we don't want to just be treatment facilities. We want to be healthcare facilities, and we want to be preemptive and more preventive and things like that. But very often, people don't go to the doctor until they're sick, and really we may do better if we schedule appointments. And like, for example, MDVIP, which used to be owned by Procter & Gamble, so Secretary McDonald should be familiar with it. And it's a program where people do pay a fee, but they come in even when they're well to make sure that they're being kept up on their medicines and things like that. And they limit their number of patients that they see. And they still do some fee-for-service type things, but things that aren't covered. Well, in the VA, it's pretty much all covered. So is there a drive towards this? Doctor, you're shaking your head, so please weigh in on that.
Well, actually, I was thinking more in terms of a comment you made before, in terms of developing better regulation of panel management and so on. And in fact, is that being deployed everywhere and so on? And in response, to actually previous legislation, we now have, clinic managers which have been hired high level with specifically that job, in order to make sure that panels are managed properly, the data is accurate, that in fact there is an understanding at the frontline primary care level. In fact, that they have some authority over their panels, and they need to be good feedback, and there needs to be this alignment of leadership at every level. And they're currently being trained. There are training programs that we've developed in the VA specifically for this. Dr. Stark is actually one of the major initiators of this.
Throughout, are they physician-driven?
The program is physician-led.
Okay, that's helpful. But to my other point too, there are models within the private sector that we may be wanting to take a look at. That say, what is the right number pay, and are we providing those visits where hey, you have diabetes and I don't want to see you when you crash. I want to see you every 4 months anyway, right. And that type of thing.
Yeah, the patient-centered medical home model, or PACT, is really the embodiment of that philosophy, and so we take that very seriously.
And are there tools to evaluate, are we actually saving money by doing that? Because I believe that overall we do, if we are truly a preemptive healthcare facility as opposed to just treating.
Mm-hmm. Yeah, we have looked at that. It's still preliminary, and it's difficult to make those assessments, but as Dr. Lynch mentioned earlier, high-performing PACTs have lower hospital readmission rates and other indicators of better outcomes that end up costing us less.
Well, might I suggest that we maybe look at some of those concierge-type services that you actually could provide, I think, in the VA, that type of entity that might be helpful for us in the long run. Thank you.
Agreed.
I yield back.
Mr. Hillscamp?
Thank you, Mr. Chairman. I appreciate the subject of our hearing today and the GAO report, which I find very interesting and very insightful. By my count, I think this is the 38th report that's documented data inconsistencies. And by the way, I just made that number up. But there has been a lot of reports on that, but the question, I guess, whether Dr. Lynch or Dr. Stark, who might add bluntly, how valid and reliable is the data that we've been discussing here, in your opinion?
I'll take a start that I think there have been some inconsistencies, and they have given us some challenges. I think that the new primary care module that will be looking at PACS are going to address some of those inconsistencies, especially in paneling patients who may have died or who may not be seeing VA, and may be looking to give us more accurate data and allow us to monitor that data.
My question, though, was validity and reliability. Could you address each of those separately of the data here? The GAO reports vast inaccuracies, but validity and reliability, can you distinguish between the two for me?
We've concurred with the GAO that our data is not reliable, and therefore there may be some lack of validity. I think, however, when we look at things at a larger level, we can get some information, but we can get better information, and we're working on that.
And appreciate that recognition, because, I mean, we've been hearing data back and forth, and if it's not reliable, I mean, this discussion is really rather fruitless until we have the reliable data. But is there punishment for employees who fail to report the data accurately, and who is responsible for, finally, at the end of the day, who at the VA is responsible for the data we're discussing?
The facilities in central office are responsible for the data. Would I blame an individual? Probably not so much as our system that hasn't provided the tools they need to provide us accurate information, and that's what we're working on.
So who's responsible then? At the end of the day, when you go back to your office and say, they asked me a lot of questions about data, I admitted it was not reliable and probably invalid. Strike one. And two, who do you call, Dr. Lynch, and say, okay, fix this problem?
Central office takes ownership for trying to put that data together, sir. And we are working to provide new tools to do that.
Is there any one person? Or who do you call? Not central office. I don't know how many people work in the central office, but who's responsible? Who's going to fix this, in other words?
There are a number of offices that are responsible. VHA central office is probably the individual group that is responsible for getting you the data that you need, sir.
But is there an individual that's in charge of this data project, or it's just a committee of folks? I mean,
It's a number of people in central office that are trying to work to solve this problem, sir.
and so they're all guilty and all responsible or all unaccountable. I'm just trying to figure.
I think they're all trying very hard to work through a system of data that's put together in a computer system that was never meant to do what it's supposed to do today. Our computer system goes back to 1985. Our system changed significantly in 1995 when we went from inpatient care to outpatient care. And our systems have not changed substantially, sir.
And we're still determining here, trying to figure out what is the appropriate panel size, even though we're not for certain we're even measuring panel size. We're not for sure what we're mentioning. By the way, does an encounter include a phone call? Is that one encounter? How do you count that?
It can be billed as an encounter, sir, yes.
Does an email to a patient, is that an encounter?
To my knowledge, right now, an email does not count as an encounter. Is that right, Dr. Stark?
If it meets certain criteria for medical decision-making, it can be coded as an encounter.
Do we know what percentage of the encounters are, and that's fundamental to the second part of the report in terms of the vast wide range of cost. So if a phone call and perhaps an email can be encountered, do you know what percentage of encounters actually fit that?
About 30% of our encounters are by telephone.
What percent are emails?
I don't have that data. That's a relatively new.
Yeah, that's only 20 years old. I get that. I'm just kidding. I don't know how long you've been counting that. But in the private sector, do they count that as encounters? Just a phone call reminder you're going to have an appointment or something like that, or?
And phone calls do count in the private sector. It's a lesser weight encounter than a face-to-face visit.
Okay, I would like a little more follow-up on the data, breaking that down what that encounter is, because that was critical to the second part of the GAO report, trying to figure out we got this wide range of expenditures, and just let you know that the piggy bank is about empty. So we need to do a better job of how we spend this money. I yield back, Mr. Chairman.
Mr. Kaufman, you're recognized.
Thank you, Mr. Chairman. Well, one thing that's not acknowledged in this report is something that I think VHA leadership is very good at, is very effective at, without parallel, and that is your ability to cut bonus checks to each other. I mean, that is extraordinary, and the amount of money spent on that for whatever reason. But let me, as someone who's involved in healthcare on the HAS side, on the Armed Services side, and on this side, that when we are severely wounded coming out of Iraq and Afghanistan are handled different than our severely wounded were coming out of Vietnam. In Vietnam, they were stabilized in the military system, and then they went to the VA for the rehabilitation. Now we extend them on active duty for the rehabilitation, unless they specifically request to go to the VA, which is very rarely done. Then they're medically retired, so they're under the TRICARE system. So I hope we can improve the VA to where we feel confident about putting our war wounded there, but that's certainly not the case today. What is extraordinary, I think, about this report, and I think about the culture of the VA, is that when mediocrity is legally protected, this is the system you get. The military system, I'm 21 years in the military, we have a number of former military officers here, well, some current, Dr. Winstrip, but it's a merit-based system. Let me tell you, Dr. Lynch, you would not survive in the military system, period. Maybe you were there at one time, and I know a lot of people in the VA come from the military, but they have forgotten all the values that they learned in the military. And let me tell you, there are a lot of good people in the rank and file of the VA, don't get me wrong, and they are the people that step forward as whistleblowers that we are trying to protect here on this committee from retaliation from leaders like yourselves. And so it's just extraordinarily disappointing that what we're seeing today. We need to make the choice program work. I think the choice program will make you better. That the fact I think you take the veterans of this country for granted. And I think that having some level of competition will be helpful. And I think we need, at the end of the day, to have some system when we get the choice program to work, that the VA isn't very cooperative in terms of making it work, that that demand needs to reflect if relative demand to the VISN, if people prefer the choice program to the VISN, then we need to bring down the number of employees in the VA for that specific VISN. That will come eventually. Let me just reference the report. The GAO report indicated that in its comments to this report, VA did not provide information on how it plans to address unreliable panel size data accountability. In response, GAO recommended that VA specifically assign responsibility for verifying each facility's reported panel size data. Who should have this responsibility, and when will VA publish its guidance identifying those individuals? Dr. Lynch.
So that would fall to Dr. Stark and his office.
Okay.
And we are in the process of validating our data as we implement the new PCMM web system to monitor our panel sizes. That's part of the process to improve the accuracy of our data.
Dr. Lynch, why do you think that the culture of the VA is what it is today? With that, why we get the scandal after scandal after scandal in the VHA system? Why do we have the wait time system where there was manipulation of the wait time for appointments in order to get cash bonuses, and that went all the way up? And I believe that the head of the Phoenix Hospital I don't think she's ever been fired yet, or do you know what the status of that person is? I understand they're on underpaid leave. Can you speak to that?
I think the former director has been terminated, sir.
Has been terminated?
Yes.
Okay. Mr. Chairman, I yield back.
Thank you. Mrs. Wolarski?
Thank you, Mr. Chairman. Dr. Lynch, several months ago we did a hearing. It could have even been last year, I don't remember, but we talked about the issues on the credentialing process for vendors and some of the confusion that had happened around the country with unauthorized vendors being in different places and that kind of a thing. So I've been working on legislation that I introduced that would create a uniform framework for enabling the presence of medical vendors. It's not necessarily a new issue, but as you examine ways to reduce the administrative burdens and improve efficiencies in your VMAX, have you considered creating a standard framework for vendor access? Has that been talked about?
We have been working following those initial meetings to come up with a process that allows us to have full eyes on what is coming into our institution, where it's coming from, and where it's going. Yes, Congresswoman.
Okay. Are you looking at solutions from the private sector organizations to help streamline that process?
I was not part of the group. I can't confirm that, but I would suspect we have been looking at the private sector. We've been doing that with increasing frequency now.
And then I would ask you this. I know you're not directly on it, but are there any things that you have heard that have come out of any of those meetings where Congress can be a partner in accomplishing that goal?
I have not heard of any specific asks for Congress, but we certainly keep that in mind.
Okay. And could you at least check on it and get back to us?
I will.
Okay. I appreciate that. And then I have a final question on the independent assessment that was released a few weeks ago, concluded that VHA and the Office of Information Technology, which I've asked about many times, are not effectively collaborating, which has hindered VA's ability to ensure IT investments align with its healthcare objectives. So who within the VHA is responsible for coordinating and establishing those objectives between those two offices?
So right now we have a new head of OI&T, Ms. Laverne Council. I think I can honestly say we have a new sheriff in town who has...
On IT?
On IT.
Okay.
Who has begun to take an interest in issues such as collaboration and understanding how the different parts of the organization can work together. I suspect at this point in time that the lead for those communications would probably be Dr. Schectman, but I suspect it will also move down as the more specific needs are identified. But there's been a change in attitude.
And you welcome that change?
Pardon?
And you welcome that change?
I do welcome that change.
And I think there has to be real change, and that there has to be a structural change to be able to enhance those interagency cooperations because of the fact the GAO report has talked about this as being a serious issue before. I've asked many, many times on this committee prior to this new IT person specifically about IT, because so much money has gone into it that's been tax money. There has not been a whole lot of accountability and transparency, and there hasn't been a whole lot of interagency cooperation at all. So I would hope, if you could take that message back, I know you're not specifically directed to it, but I would hope that we'd see improvement in those two. And again, so that the end goal is to helping the veteran get the health care they were promised. And with that, Mr. Chairman, I yield back.
Thank you, Ms. Walorski. I want to thank all of you for being here today to give us your testimony. Mr. Williamson, Dr. Lynch, Dr. Stark, and Dr. Schectman. I think you pretty much got the idea that a lot of us are very frustrated about the rate of change, or the pace of change. The reassurances that you're on it, are all well and good, Dr. Lynch, and I believe you're sincere. It's just that at this level here, we get very frustrated by the pace of the actual change, and Mr. Williamson's just put it all in his report today, and you said all of a sudden we find out there's already been change in the way that they're going to do it. They're implementing the new software. But we haven't really seen the results of that. So we'd like to see.
I think I say, Mr. Chairman, we welcome the opportunity to come back and share with you the results that we are finding as we implement that software.
Yeah, well, I'm hopeful that will be soon. So if there's no further questions, you are all excused. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and to include extraneous material. And without objection, so ordered. The hearing is now adjourned. Yeah, good to see you, man. Yeah. Okay. Good job.
Nice job.